Absolutely. I think this is a question that's on everyone's mind right now since that groundbreaking ESMO presentation. And so I think there could be a role of chemotherapy in the second-line setting. So platinum-based chemotherapy with gemcitabine, whether patients are still eligible for cisplatin, if they have residual neuropathy from that EV pembro, is a big question on everyone's mind. Otherwise, we still have the option of carboplatin with gemcitabine. And then beyond that, the question is, if you did go that chemotherapy route, is there a role for maintenance of avelumab? We have seen that IO rechallenge in other disease states, such as in kidney cancer, has not been successful. We do have some trials right now looking at sacituzumab with or without immunotherapy in the second-line setting, so I think it will be really exciting to see how that reads out. If in bladder cancer, the biology is a little bit different in terms of immunotherapy rechallenge. And then the role of sacituzumab on its own or with this combination in this trial is also a big question on everyone's mind. So chemotherapy in the frontline setting has response rates in about 44% range. Sacituzumab has shown about response rates of 27% in the line in which it's approved. And so is that going to perform the same way in the post-EV pembro setting? We don't know the answer to that yet. And then finally, I think for patients that have FGFR3 mutations or amplifications, the question is what is going to be the efficacy of erdafitinib in the post-EV pembro setting as well? I think in an ideal world, we would have comparative data in this setting. However, I think the way that the landscape is moving, we're going to have individual trials for some of these questions, trying to see what the efficacy is for each of those classes. And so at the end of the day, we will be faced with the decision of choosing one regimen over the other, not based on comparative data, but based on these other trials. I think this was an interesting abstract because it looked at real-world data in terms of the safety profile of sacituzumab in the real, and so they had about 86 patients, and 65% had EV as their immediate prior line of therapy, and a total of 71% of patients had EV in any line prior to sacituzumab. And they found similar toxicity profiles to what has been seen in the TROPHY trial for which sacituzumab is approved. So we see neutropenia, we see GI toxicity, and they showed that about 25% of patients in the real world got primary GCSF prophylaxis with sacituzumab, and none of those patients had severe neutropenia. So I think this educates us in terms of trying to get insurance approval for GCSF with this sacituzumab regimen. And the other part that I found interesting about this abstract is that only half of patients required dose modifications. The remainder of the patients were able to remain on that 10 milligram per kilogram day 1 and day 8 of the 21-day cycle for the duration of their treatment on sacituzumab. We don't have efficacy data from this specific abstract, but I think it was interesting in the sense of what the toxicity profile is in the real world, in the post-EV setting, especially as we are thinking about using sacituzumab in the post-EV pembro setting. I think there's still some work to be done in terms of guidelines, especially when it comes to toxicity management of these antibody drug conjugates. This has been kind of a new era of cancer treatment, and we definitely need to replicate the toxicity management of what has been seen with checkpoint inhibitors, where we have very established guidelines that are very easy to access, grade 1, 2, 3, 4, what to do, when to initiate topical steroids, systemic steroids, depending on what the toxicity is. And so I think that we do need to replicate that for these antibody drug conjugates. So there is more comfort in terms of using it not just in academic settings, but also in the community.